Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Alexander Price from California, United States. Dr. Price is an orthopedic oncologist who specializes in treatment of both benign and malignant tumors and related conditions of the musculoskeletal system. He has a special interest in limb salvage and reconstructive techniques following treatment of bone tumors. Dr. Price graduated from the Yale University in New Haven, Connecticut, with a BS in molecular biophysics and biochemistry, where he also pitched in the varsity baseball team. He then earned his medical degree from the University of California, Irvine School of Medicine. Dr. Price then completed his orthopedic surgery residency at the Hospital for Special Surgery in New York City, the top-ranked orthopedic residency program in the country. Following residency, he completed 2 years of additional subspecialty fellowship training in adult reconstruction and joint replacement at Hospital for Special Surgery and also at the Musculoskeletal Oncology in the Sloan Kettering Memorial Cancer Center. Dr. Price is passionate about scientific research that can improve the lives of patients with musculoskeletal tumors, and he has published on a variety of subjects and topics in peer-reviewed journals. Specifically, he's interested in sarcoma genetics, drug delivery, and advanced reconstructive techniques after tumor removal. So today it's my great honor to introduce you to Dr. Alexander Price from California, United States. Over to Alex.
Well, thank you so much for having me. It's an honor to participate in this program and to hopefully share some knowledge as to the way we've been thinking about how to treat surgically and non-surgically metastatic disease of the acetabulum. As you can see, I was just at University of Southern California, and I've just moved my practice over to UCLA, where I'm now the fellowship director for the Orthopedic Oncology Fellowship. So it's an honor to be here and hopefully share some of our thought processes behind how we approach metastatic disease of the acetabulum. These are my disclosures, sorry, for anybody who's interested. And so when we start off thinking about metastatic disease of the acetabulum, this is the seminal article by Dr. Harrington describing his experience, in over 60 patients from 1972 to 1979. What we see, and this is again published in 1981 in JBJS, and what we see is that median survival following the first pathologic fracture was about 18 or 19 months. Breast had a slightly longer survival time of about 23 months, and lung was dismal, less than 4. Dr. Harrington in this kind of described his classification for addressing acetabular defects for metastatic disease. And importantly, in his study, all patients underwent radiation. And you can see again, about a third of the patients, a little over a third, were metastatic breast cancer, and then a variety of other sites. And so, looking at Dr. Harrington's classification on table 1 over on the left, class 1, pretty straightforward defect, just a little bit of metastatic disease. Class 2, deficient medial wall. Class 3 starts to get a little bit more complex with a deficient lateral cortex and posterior wall. And then class 4 was described as isolated lesions that could be resected and attempted cure. And for metastatic disease, we really kind of think of this as something like a solitary renal cell carcinoma metastasis. Over on the right, not that Dr. Harrington's system is the only classification system. This is the metastatic disease classification from AAOS in this paper by Paul Isaac. So slightly different classification, but kind of very similar way of looking at the problem. So what Dr. Harrington recommended, for class 1, pretty much the entire acetabulum intact, was standard cemented total hip arthroplasty. For class 2, with a medial wall defect, the recommendation was a cemented total hip arthroplasty with an anti-protrusio ring. And for class 3 defects, the recommendation was removal of all gross tumor back to solid bone, pin and screw reinforcement, and possibly the use of an anti-protrusio ring, and then cemented total hip arthroplasty. But as you can see, from the figures described in his article, this procedure gets a little bit more complex. And so from some of these images, you can see very large acetabular and periacetabular defects, multiple pins and screws, large cement block area, and then cemented hip arthroplasty. And again, this can be done in a variety of ways, retrograde pins or screws, antegrade pins or screws, plus and minus protrusio cage. And then again, class 4, these are lesions that you're resecting the entire lesion widely in an attempt for a cure. And everybody's recommendation is just try your best. So it could be a total hip, girdle stone, hemipelvectomy, whatever you think you can, whatever you think you can do to keep the patient safe and accomplish your goal. There's a saddle prosthesis. But I think, even looking at kind of what equipment they had and techniques and everything is relatively primitive compared to what we have today. And Dr. Harrington's results were quite good. So if you look at table 2 over here in terms of pain, a large proportion of the patients went from having moderate or severe pain to minimal pain, even 6 months and 2 years postoperatively. And many of these patients were able to become ambulatory again, either with no aids or 1 cane or 1 crutch. So I still think, amazing results for that time period. And I think this is obviously the paper and the concept that we all judge this disease entity and how we treat it by today. And again, the equipment then relatively rudimentary, so we have, anti-protrusio rings, some cages or gap cups, Steinman pins, and then essentially, first generation cemented stems for total hip arthroplasty, cemented all poly acetabular components, and a lot of bone cement. And so I think, again, I find this very impressive given what they had to work with. And I think this will come into play later as we think about what we can do today. So another thing that we need to think about is kind of the changing face of metastatic disease. And so we were all taught in medical school that the carcinomas that most commonly go to bone, in the United States, the acronym, is BLT with a kosher pickle. So breast, lung, thyroid, kidney, and prostate disease. But if we fast forward to today, the face of metastatic disease to bone is changing. So if we look at kind of the scope of the problem now, bone is a frequent location of metastatic cancer. If we look at some of the most common diseases like breast and prostate cancer, bone metastases can be found in up to 70% of patients on postmortem analysis. So we know that the percentage of patients that have this and may deal with this problem is incredibly high. Symptomatic bone metastases complement the course of about 40% of the most common carcinomas. And so in the United States alone, this affects about 400,000 people annually. So a huge implication from a public health standpoint. And we know that the pelvis is the 3rd most common site of bone metastases after the spine and femur. This is some of our data that when we looked into kind of the scope of the problem, we presented this at the International Society of Limb Salvage meeting last year at UCLA. And actually this data was just accepted for publication in the Bone and Joint Open Journal. And so everybody will get to kind of be able to evaluate and read the whole data set soon. But using the Premier Healthcare database, we were able to identify over 400,000 unique patients with metastatic bone disease from about 2015 to 2020 in the United States. We analyzed over 14 different tumor subtypes, and the frequency of complications was analyzed as well. When we looked at what carcinomas are causing metastatic disease to bone now, in a contemporary cohort of patients, what we see is, not surprisingly, lung is most common, almost 25%, followed by prostate and breast. So this is what we expect. But gastrointestinal now is 9.4%. And so this is in contrast to what we used to think before, where we would think, kidney and thyroid were probably the next 2 most common. And so we are seeing a shift in terms of what diseases are going to bone as patients are living longer. And as we all know who have to treat this regularly, some of the gastrointestinal tumors that go to bone, such as colorectal cancer, stomach cancer, prostate, these are a different entity than breast and prostate cancer, and a little bit more difficult to treat. When we look at which tumors are causing pathologic fractures, urologic, so kidney cancer is the most common, followed by female reproductive, which is pretty interesting, and then lymphoid, endocrine, breast, and lung. And so what we see is that the 90-day mortality rates following treatment of pathologic fractures of the long bones, at least, is about 12% for lung, 10% for GI, and about 10% for the CNS. And so we do see kind of a shift in exactly what tumors are causing metastatic disease in bone. And so we need to be aware of this going forward. The other thing that we're starting to see, over the last 10 to 15 years is incredibly increased survival. And so this is wonderful for patients, but it means that our reconstructions have to do better and be more durable. If we look at kind of what's been in the news over the last 10 years, targeted therapies, so, checkpoint inhibitors and immunotherapy have exploded onto the cancer treatment scene, and for many diseases are now standard of care. You can't go a day looking at cancer news without seeing information on how immunotherapy or targeted therapy is increasing the lifespan of patients with metastatic disease. And so these are just headline after headline. UCLA Health, NCI, New York Times, every medical blog. And so we need to be aware that our patients are going to demand more of these reconstructions, and we need to do a better job than we did in the past. We also now have tools for survival prediction. So this is the PathFrax website. And so, this is an incredible resource using Bayesian analysis to kind of predict survival after a pathologic fracture. And you can put in a number of the patient's characteristics and kind of get this output giving a survival prediction based upon time points for each one of your patients. And one of the cool things that PathFrax is doing now is for specific tumors and specific locations, actually, they're giving reconstructive or treatment recommendations. So we know a lot more than we did, 20 or 30 years ago, and we have a lot more tools now so that we can kind of decide upon what reconstructions may fit our patient the best, either limiting the morbidity of the procedure or, improving the durability and longevity of the procedure depending upon what they may need. And the other cool thing is, our equipment now is much different than what we had before. So, looking at this screen, this is just kind of, a couple selected items that I've used in the past to deal with metastatic disease of the acetabulum and pelvis. And so, we have, porous metal ingrowth surfaces, cannulated fenestrated screws, custom acetabular components, dual mobility, all sorts of cages. And we have certainly, the ability to use computer navigation and other kind of enabling technologies to be able to reconstruct things in a more minimally invasive or accurate way. And so, we have a lot of tools now in the toolbox that we didn't 30 or 40 years ago. So I think we have the ability to do a much better job. And so kind of going back to looking at mainstays of metastatic disease treatment. So our patients that come in with metastatic disease of the acetabulum, what do we need to do for them? Number one, this is a team approach. Multidisciplinary care is paramount. We need to obviously be in touch with the medical oncologist, radiation oncologist, their primary care doctor. This is all of us working together to give this patient the best outcome we possibly can. We certainly need to focus on their general health. So their nutritional status and metabolic status is paramount because they need to heal and be able to tolerate systemic therapy. For any metastatic disease to bone, radiation is first-line therapy. This can be in a number of different regimens, depending upon the disease, usually giving 25 to 35 gray over limited fractions. But this needs to be the mainstay. And I think, where we've seen a lot of failure in the past in the orthopedic literature is kind of variable use of radiation in these patients. Systemic therapy is paramount. If we do not have effective systemic therapy, we're not going to be able to control the disease. So looking to our medical oncology colleagues and obviously the explosion in targeted therapy and immunotherapy has been, incredible for our patients. The standard use of bisphosphonates has completely changed the game in terms of number of skeletal related events for people with metastatic disease to bones. We need to make sure our patients are getting bisphosphonates if they can. Pain medication and management is always important. And then finally, surgery is reserved for disabling pain or an impending or completed pathologic fracture. So we're kind of the last line of defense here, and we need to make sure our patients are getting optimized from all of these other different perspectives to get the best outcome possible. So if people do need surgery, we've decided that this is the best course of care for them for metastatic disease of the acetabulum. What are our goals? So we think about metastatic disease principles, and the goals are simple. Pain relief, immediate stability and durable fixation, meaning allowing them to weight bear right away, and restoration of their ambulatory function. These people need to get back to their lives. They need to be able to get back into the medical oncology clinic. So we need to give them something they can walk on right away. Secondary goals, obviously, we want to think about minimal interruption and systemic therapy. And so appropriately timing surgery if possible and trying to limit the complication profile so they can get back on treatment. And this is a picture of my mentor from Sloan Kettering, Dr. John Healy, who taught me, so much in terms of the field of orthopedic oncology, and has been my mentor throughout my professional career. And a couple of things he would say: number one would be the punishment should fit the crime, and the other one would be the Goldilocks principle of orthopedics. So not too much surgery, not too little surgery, just right. And so if you look at this patient from before, metastatic disease of the acetabulum, relatively straightforward. Cemented acetabular component with a couple screws and a cemented stem. Not too much, not too little, but just right for this patient. And so when we look at how the traditional Harrington framework or technique has performed in the literature over time, thankfully, we do have a lot of information that we can look at. So this is a great paper by Michelle Gert from CORE in 2007. Looking at 63 patients at McMaster University. They had 2 perioperative deaths, 2 dislocations, and 2 periprosthetic fractures. But what they did demonstrate was incredibly effective pain relief, improvement in functional status from an ECOG of 2.6 to 1.1, meaning the majority of these patients became eligible for chemotherapy again. And so that's incredibly important for their survival. However, still we see short overall survival times with breast cancer outperforming other malignancies, but still, once you get to about the 5-year mark, survival is under 10% for both. We see similar results from this across several studies. So we see, coming out of 2009, coming out of Beijing, 17% complication rate with standard Harrington technique. Out of Sydney, 20% mechanical failure rate. Out of Brussels, 48% complication rate. So while we're doing a good job and all these studies demonstrated effective pain control and improvement in functional status, still kind of a high complication rate from a surgical perspective. And the challenges or failures that they encountered, included problems with fixation and, again, non-standard use of radiation therapy. So, probably inadequate local disease control. Looking at certain types of reconstruction, such as, cemented cup with reinforcement screws for Harrington type 2 and 3 defects. These actually did pretty well. If you look at, the series in 2008 out of Birmingham, only 1 revision, no dislocations. You look at the combined series by, now my new boss, Dr. Bernthal, combining UCLA and Utah's data in 2015, only 5 out of 52 were revised with 1 dislocation, pretty good. But there were still some other papers demonstrating poorer outcomes. 2010 out of USC, 41% complications, 6 dislocations out of 37 patients, so high. Out of Istanbul, 16 patients and 1 pin migration and 1 dislocation. So we'll get into some of those issues later. And so the take-home points I get from some of these papers are, smooth pins can migrate, which seems obvious, but something to remember. And that increased soft tissue dissection is going to lead to increased dislocation. So if we have to do a large dissection, we need to do something to try to prevent dislocation of the hip. Duh. And so now kind of moving into even larger reconstructions, flanged cups and roof rings for type 3 defects. Again, we have a decent amount of data coming from different high volume centers. University of Rochester study showed that with screws in a roof ring through a variety of approaches, meaning anterior, posterior, lateral, no mechanical failures in 21 patients. So pretty good durability of fixation. Out of Sweden, same thing, roof rings that they used in about 11 out of 31 patients, no mechanical failures. The Sloan Kettering data, they had an 11% failure rate in 55 patients. Almost all of these were due to local progression, and only 56% of the patients received radiation therapy. So again, emphasizing that, while we can do a good job with the mechanical portion, especially with flange cups and roof rings, disease control is paramount. And so we still need to make sure our patients get radiation therapy to control the local disease. And so the take-home points from these studies, I think, are that flanges and roof rings work, and that disease control is still paramount. And so now kind of bumping up to some of our larger reconstructions, so cage reconstructions and type 3 defects. And so historically, these have had, high dislocation and infection rates, and I think that makes sense. Increased soft tissue dissection is going to lead to increased dislocation rates, and it's going to probably lead to more infections. So if we look at the data out of Australia from the Royal Adelaide Hospital, 29 patients, 12-month survival, 10% deep infection, 17% dislocation. So pretty high complication rate. From Germany, they described, loss of ischial fixation as kind of their mechanism for failure of these cages. From the Karolinska Institute in Sweden, 70 patients, 33% complication rate, with dislocation being the most common. And again, from Australia, 47 patients, 4 dislocations, 1 deep infection, and a 16% revision rate at 4 years. So, what are we seeing here? I think, again, you have a big defect, you need a large dissection and putting in a cage. This is going to cause soft tissue disruption and increase your risk for dislocation and infection. But there is, there is some hope on the horizon. And so I think these 2 papers really helped me understand how to think about this problem a little bit better. The one on the left, looking at 131 hips with metastatic disease and 126 patients. They used a dual mobility cup cemented into the cage in every case, and they brought their dislocation rate back down to 2%. And what was so interesting in this paper is that 2/3 of these patients were done in conjunction with a proximal femoral replacement, so some sort of abductor deficiency, and they were still able to bring their dislocation rate down to only 3 patients and 131 hips, and no instances of mechanical failure or aseptic loosening. So I think this is pretty incredible. And again, the paper on the right, looking at the use of constrained liners during Harrington hip reconstruction, 68 patients. They used a constrained liner in all of these procedures. They found no dislocations, and they also found no mechanical failure. So the constrained liner didn't predispose to increased aseptic loosening. And so again, I think these 2 papers help us understand that if we're going to need to use a cage or a large soft tissue dissection to take care of the defect, using some sort of different bearing, whether that be dual mobility or a constrained liner, can certainly help us decrease the complication rate for our patients. And so this is the paper using dual mobility, and I think that's a really beautiful reconstruction right there using that cage. There are also some other technologies, that are available that haven't been more commonly used in metastatic disease of the acetabulum, but I think may hold some promise in the future as our patients are living longer. So, there has been some data looking at porous metal, and in this case, it's porous tantalum in the setting of metastatic disease. We know that this has been effective in the post-radiation setting, but looking at some of the data from Mayo, from the paper by Kahn in 2012, they looked at 20 patients with 26-month follow-up and found no mechanical failures and only 1 dislocation when they were using press-fit porous tantalum to treat metastatic disease of the acetabulum. Matt Hudek wrote the follow-up to this paper in 2020, and so they were looking now at 58 patients with 8-year follow-up for surviving patients, and they had no acetabular failures and only 2 patients that had radiolucent lines about the acetabulum. So this is really durable fixation for patients that have a longer life expectancy, even with metastatic disease. And then finally, looking at Matt Hudek's paper comparing the Mayo and the Toronto experience, 37 tantalum reconstructions to 78 Harrington reconstructions that were performed with a cemented acetabular component and smooth pins. If you look at the 10-year revision rate for loosening, it was almost 10% in the Harrington group, again, smooth pins with a cemented acetabular component, and 0% for the tantalum group, and the Harrington group had statistically more reoperations. So we may find some value in the future for our patients with longer life expectancy using these porous metal ingrowth surfaces to reconstruct the acetabulum in the setting of metastatic disease. Now, other reconstructions have been tried, and I'm just bringing these for everybody's kind of knowledge and completeness of understanding. Saddle prostheses, as you can see up on the top right, have had high failure rates that include dislocation, infection, and iliac wing fracture. And I think these are have fallen out of style. I don't really know anybody using these currently. Custom flange implants, I think these are something that we may see on the horizon. There's a lot of enthusiasm for these given their success in revision total hip arthroplasty. So far, widespread use has been limited by manufacturing time, which used to be up to 3 months. Cost, and the cost is about the same as a porous acetabular cup and 2 augments. But now 2 companies have FDA 510(k) approval, and I think a third one is coming. And some of the manufacturing times have been brought down to 6 to 8 weeks. And so for patients who do not need surgery immediately, I think these hold promise in terms of treating this entity. And then we've also seen cone prostheses, which have been successful in primary bone tumor reconstructions with impressive results. Currently in the United States, all of these options are custom, meaning that you have to go through the FDA and the IRB. But there's a company that is likely coming out with an off-the-shelf option soon. And so this may be another tool that we have in the toolbox to take care of these patients. And we just see up on the top right, looking at a dislocation of a saddle prosthesis. And as our former president would say, sounds good, but doesn't work. Shifting gears a little bit, I think sometimes as surgeons, we forget that a lot of these patients may be amenable to less invasive interventional procedures, especially those patients that are a little too sick to currently tolerate an open surgery. So, the cement acetabuloplasty, so kind of injecting cement into the defect, was described by Coton in 1995 and 1999 in France, and used for periacetabular disease not involving the joint in patients who could not undergo surgical intervention. What we see in these is what we see in this using this technique is pretty good results for at least 6 months. So 2 papers out of Italy showed no major complication. Pain relief usually starts to decline after 6 months. And one of the advantages is that most of these patients are same day or 23-hour discharge. So this gets them out of the hospital pretty quickly. Also, this can be combined with other techniques. We see this paper in 2018 out of the Mayo Clinic where this was combined with cryoablation, 39 procedures in 37 patients. And interestingly, they found no pain difference in patients who had incomplete versus complete ablation, but they did see a 20% new and progressive fracture rate. And it can also be combined with RFA. And, so we look at a large series of that out of WashU in 2016, large series being 12 patients, but no complications, and 73% of the patients had good pain relief. So these are good options for patients who are not physically fit to undergo a larger open procedure. And then finally, some new techniques are on the horizon and are gaining popularity that I think we could really, our patients could really benefit from, and most practicing orthopedic oncologists are going to have to know how to do sometime in the near future. So this paper by Ray Yang out of Montefiore was really kind of the seminal article for this, but he described a novel tripod percutaneous reconstruction for periacetabular lesions. They showed 20 consecutive patients, 18 of whom were Harrington class 3. They inserted percutaneous screws and cement using fluoroscopy. 80% of these patients were out of bed on post-op day 1. Interestingly, 20% eventually required a staged total hip. But what they described is that these total hips were quite simple because all of the periacetabular disease was already reinforced, and they found significant improvements in VAS pain score and ECOG score. So pretty impressive technique and outcomes, at least in the short term. And then we've also described the series by one of my mentors, Nicola Fabry, when he was at Sloan Kettering. And this has been written up as an ICL in a review paper and presented last year at ISOLS, using a similar technique, but using CT-based navigation, either the O-arm or the AeroBed. This is performed on 14 patients with significant improvements in pain, morphine requirements, and all patients improved their ECOG score by greater than or equal to 1 point. And they found the pain relief durable up to 12 months in the 9 living patients. So these percutaneous procedures, I think, are going to increase in popularity as these patients, who have large lesions around the acetabulum and pelvis and can't really tolerate an open surgery. We can still help them and get them out of the hospital and back on therapy. And so these are some of the images demonstrated from Dr. Yang's paper. And again, I put up pictures of Ray Yang. He was a fellow at Sloan Kettering when I was a resident. And so we got to work together. And I know Ray very well, and he's an incredibly smart and talented guy. And his co-author, Dr. Huang, who's now chief of tumor at Montefiore, but he was my medical school mentor at UC Irvine. And so I guess what I should say is I'm not surprised that these two very, very bright people were able to develop and publish on this technique. And I think all of us in orthopedic oncology and our patients owe them a debt of gratitude, as this is going to become increasingly more common and popular in the years to come. And so this is one of the cases described by another one of my mentors, Dr. Fabry, using the O-arm to do percutaneous fixation of this periacetabular metastasis. So you can kind of see the table set up with the O-arm, some of the navigation images, and then the X-ray and CT scans of the defect, and then the final post-operative X-ray with the defect reinforced and a screw actually down the posterior column as well. So another really wonderful way to address these problems. And the current patient shown was at the last follow-up was 7 months out with clear cell renal cell sarcoma and ambulating with no assistive devices. And so pretty amazing outcomes for a relatively minimally invasive procedure. And so kind of going to what do I do now? And so how do we look at these patients today and choose what interventions may be best for them? And so when I think about that, we still go back to the paper in 2003 by Dr. Wonder out of Toronto in terms of principles for dealing with acetabular metastasis. Number one, remove as much gross tumor as possible if you're doing open surgery. Number two, reconstruct the subsequent defect. And number three, try to mechanically bypass that defect with fixation back into normal bone. And so I think these are great principles on how to get started thinking about what you're going to do for these patients. But I'd like to add a couple other principles. So what do I do now 2.0? I think near universal use of radiotherapy is essential. We need to have disease control at the local site. We need to start incorporating disease course and current and potential therapies that these patients can have to decide essentially how durable these reconstructions need to be and how much surgery is just right for each individual patient. And again, thinking metastatic disease principles all along the way. Pain relief, durability, and minimizing the complication and reoperation rate. And so the patient that you see depicted up here, this is an elderly gentleman in his 80s who had a atraumatic acetabular fracture through a multiple myeloma in his acetabulum. And so we actually did bone grafting, a press fit cup, and a cemented stem. And last time I saw him, he was a year out of surgery, walking with no assistive devices and no pain. And so thinking about what we want to do today, I think for contained defects, a standard cemented total hip arthroplasty works great. You can use screw fixation to kind of reinforce any of these larger defects. I do prefer fully threaded screws in all of these cases, as smooth pins can migrate, as we've seen. And screws should ideally bypass the defect and gain some stable fixation in native bone. For cavitary medial wall or dome defects, so kind of Harrington class 2, I personally like a cemented cup cage construct, which I learned from Dr. Fabry. This and requires intact iliac and ischial bone stock. So that's an important point. And I do like to use dual mobility routinely in these cases to decrease the dislocation rate associated with the increased soft tissue dissection necessary to place this cage. And so this patient that I have presented, she presented to me with a pathologic fracture through her acetabulum in previously radiation treated breast cancer. She also presented with an ipsilateral foot drop and had a compression fracture in her lumbar spine. My spine surgery partner decompressed her and fused her. Her foot drop actually resolved. And then we went on to perform this cemented total hip arthroplasty with a flange ring, cemented dual mobility, and cemented stem. And she lived another year after this and was ambulatory and had no pain in her hip. So this is a successful reconstruction for her. And this is just another way to do it. This is a patient with metastatic renal cell to the acetabulum and superior pubic ramus. And again, we used a cage with a dual mobility and cemented that into place, and that works quite well for this problem. For diffuse disease, I think this requires diffuse fixation throughout the hemipelvis. So this is kind of changing our thought process a little bit. Kind of more of a classic, what we would call a Harrington reconstruction. So antegrade iliac and possibly pubic and ischial screws. Again, my preference is for cannulated, fully threaded screws, either 6.5, 7.3, or 8.0, depending upon the size of your patient and the defect that you're dealing with. And I think in these cases, there is increased interest in fenestrated screws with kyphoplasty type cement so that we could actually cement through these screws and give them even better fixation. And I think also you are able to combine this technique with flange or anti-protrusio acetabular components if you need to. This patient presented up here. This is a guy who presented with a pathologic fracture, no known disease. Blood work demonstrated they had multiple myeloma and really, kind of diffuse disease of this acetabulum with not much bone stock left. So again, I chose diffuse fixation through the pelvis with cannulated, fully threaded screws, and then a cemented hip arthroplasty with an all poly cup that does include kind of a flange component around it to prevent protrusio. And so this is the X-ray from the side, kind of demonstrating how all of those screws come down from the ilium and create kind of a reinforcement barrier throughout the acetabulum. And that's him at final follow-up 1 year later on therapy. Again, looking at another case with diffuse disease. So this is a patient with metastatic breast cancer, and you can see diffuse tumor all throughout her hemipelvis. She required also proximal femoral replacement. So in this case, antegrade, pubic screw, retrograde ischial screw up the posterior column, 2 screws from the ilium, and a cemented dual mobility. And finally, using cement acetabuloplasty, this is a patient, very, very ill, widely metastatic thyroid cancer. And so she had already had a hemiarthroplasty on one side. We were worried about the morbidity of doing the acetabular component on this side, and she had good cartilage. And so we did a hemiarthroplasty on the right side, put 2 screws in percutaneously and cemented the acetabulum. And this allowed her to resume weight bearing. And so in these sick patients unable to tolerate more invasive surgical procedures, certainly cement acetabuloplasty or interventional procedures can be quite effective. And you can also still use it in combination with other reconstructive techniques. And finally, wide resection. I mean, this is really reserved for solitary metastasis, where wide resection may confer survival benefit. Right now, the only data for this is in renal cell carcinoma. For these patients, you can consider custom flange or pedestal implants, but the morbidity of wide resection is not warranted for patients with multiple bone metastases. And so now, what are we looking to in the future? What's the future of metastatic acetabular recon? And so I think the volume is going to be the biggest thing. If we look at this article in BMC Cancer, looking at the incidence of bone metastases in patients with solid tumors, these are patients from 2004 to 2013 in the United States. The incidence is just going to increase. So I think all of us need to become increasingly more familiar with durable reconstructive techniques in these patients, because there's just going to be more and more of them that are going to need our help. And again, we can see the number of patients with bone metastases over these different histologies, prostate, breast, lung, and others, as a function of time from their first bone metastasis. And you can see, especially with prostate and lung, the rates of having a bone metastasis are going to be somewhere around 30% for prostate and over 10% for lung. So we're going to have to get familiar with these patients and be comfortable doing these procedures. I think more and more technology is going to be used in the treatment of these patients. What technology that's going to be, I think it's going to be dependent upon the surgeon and the institution and what these patients need. But we now have, vascular suites with biplanar fluoroscopy. We have surgical robots, imageless navigation, O-arms, arrow beds. So I think, whether you're this guy, or this guy, whether you are interested in technology or not, this is the future, and we're going to have to use some of this for, more increasingly use technology for these patients. So I think it's incumbent upon all of us to learn what's available and how to use it to help our patients. I also think that the future of this is going to be go hand in hand with cost to our healthcare system. So, as we see the future, more and more patients are going to have these cancers, and more patients are going to be living longer with their diseases, and they are going to need more technology and durable reconstruction needed. So this all equates to increased cost on our healthcare system. The ethics of this are challenging. Who's going to shoulder the additional cost burden? And the fact that we're going to be spending more money on patients with a terminal disease and with limited healthcare dollars, how we're going to decide how to spend them, and the ethics of that is going to be something that we're all going to have to work on and determine. I think our job is to be an advocate for our patients. So we're going to need to demonstrate to insurance companies, to our federal and governmental healthcare systems, and to our hospital administrators, the importance of taking care of these patients and investing in their care, because we do see that from all the studies that we've shown, from Harrington's study to today, that our interventions for these patients are effective, and that we need to support them. And finally, I think we need to focus on multidisciplinary care in the future. Increasingly, we're going to need to coordinate our care with our medical oncology and radiation oncology colleagues. We as orthopedic surgeons are going to need to understand kind of the basics of radiation therapy, chemotherapy, the patient's targeted therapies and immunotherapies, and we're going to have to time and work our surgeries around this. So we need to work smarter. We need to do a better job of understanding and predicting patient survival so that we can choose the appropriate construct, durability, invasiveness of surgery, and have some shared decision making with our patients. And finally, you need to know your tools. So kind of some of the stuff that we already showed and talked about, but understanding implants available, technology, and the techniques that you can use to treat each patient individually and give them exactly what they need to kind of get back to ambulation and back on therapy. And always, I think, ask for help. Many of these cases, especially with percutaneous screw placement, I'm not as familiar with those techniques as Dr. Yang or Dr. Huang. And so I've asked my trauma colleagues for help, and I think that's the right thing to do. I think anytime you're going to something complex, you turn it into a team sport and do the best thing for the patient. So no shame in asking your colleagues to help you get the best outcomes. And finally, all of this information, we finally got our manuscript accepted and published in HIP International. And so I'm very excited that everybody will be able to go back, PubMed or wherever you want to find it, and be able to kind of read the concept in detail or refer back to it. And again, our metastatic disease prevalence data just got accepted to Bone and Joint Open, and so that'll be available for everybody soon. And finally, I just want to thank all of the people I've been able to become colleagues and friends with throughout my journey in orthopedic oncology. And I think this is incredibly important. Mentorship and working with your colleagues, you get to learn so much. It helps develop your ideas, helps you think about things in a way that maybe you didn't consider them before. And I think by interacting with our colleagues, forming these close bonds and helping teach each other, we all learn more, and then we do a better job treating our patients. And again, I got to thank my team at home, my wife and kids, for everything that they do to support me through this journey in orthopedics. So with that, I want to conclude the lecture and say thank you guys for tuning in and learning a little bit more about metastatic disease of the acetabulum.
Thank you, Alex. Alex, you can stop sharing, actually.
Okay.
Thank you, Alex, for this brilliant presentation, and congratulations for the absolutely stunning work that you do at LA.
Thank you very much, and thank you so much for having me here. It's really been an honor and a joy to come join you guys.
A few questions, Alex, from our side. Now, Alex, some of these metastatic disease patients have a shorter survival time, right? So the life expectancy is reduced. And do you think the trend towards future would be a less invasive surgery? For example, percutaneous cement and screws are going to be the future rather than extensive surgery, the Harrington type of reconstruction, the ice cream cone, etc.
Yeah, I think what's going to happen is that hopefully we're going to do a better job in understanding which patients need which. And I agree with you. We do have a lot of patients that are have a lot of pain. They're towards the end of life, but they do need some sort of stabilization. And for those patients, I think the trend towards minimally invasive surgery, kind of percutaneous screws and cement, is going to explode, because I think, as we saw from some of these initial papers, those techniques are very effective, especially in the short term. And for those patients is going to be, monumental in really improving their quality of life. I think on the other side, I think there are going to be some patients that really require even more durable reconstructions, especially, now we're seeing people walk into our clinic who have had metastatic breast or prostate cancer to bone and, for 10 or 15 years, and they kind of laugh. They sit there and say, well, I was told I had a terminal disease a decade and a half ago, and I, still here and still, doing fine. So, doc, what do we do about this? And I feel like those are the patients that actually, maybe we're going to move over into even more durable reconstructions. So either custom implants or press fit implants that may get some bone ingrowth that'll last them a long time, kind of more akin to what we do in standard total hip arthroplasty. So I think what you're going to see is this spectrum is going to get wider and wider, and that's going to force us to get better at a wide variety of techniques to treat all of those patients.
Thank you, Alex, for that. And Alex, what do you think about the role of cryoablation radiofrequency? Of course, you've mentioned about it. What is the trend in the US of using cryoablation and radiofrequency as a percutaneous technique?
I think it's increasing at the large centers, and there's a lot of interest in it, especially because, with these patients on all of these different therapies, and many of these therapies are going to inhibit their ability to heal. There's a lot of anti-VEGF therapies, anti-platelet derived growth factor therapies, and so we don't want to take these patients off their chemo, because that's going to hurt their survival. So I do think the interest in using these percutaneous, radiofrequency or cryo and kind of cementoplasty, it is going up. People are starting to do labs to teach it now. So I think that just indicates that, the interest is growing and people want to know how to do it because they think it's an effective intervention.
Thank you, Alex. Now, Alex, you're a guy who believes in cutting edge technology, right? So what do you think is the role for 3D printing? Some of these processes require 3D printing technology to generate them, right?
Yeah. And I think in the past, the big problem or the barrier to some of these technologies has been time. If you sit there and tell one of these patients, hey, we're going to go make you a custom implant, it usually takes about 3 months. They don't have 3 months to sit and wait around. Also, a lot of these implants, again, were custom. You'd have to go through your IRB, through the FDA in the United States. And so it was a very cumbersome procedure to try to actually get these for the patient in a meaningful amount of time. Now that some of the processes have been kind of what we call 510K approved, meaning that you don't need to, it's not custom, you don't need to go through the FDA anymore or your institutional IRB, and they're whittling down the manufacturing time. So I think some of them have been done as fast as 5 weeks, and that may be appropriate, especially in timing it with the patient's therapies, chemotherapy and whatnot. And so I'm excited because I think that will be more of an option, these 3D printed implants that can, fit each specific patient. And I think as we just get better and better and faster in manufacturing them, we're going to use them more and more.
Thank you, Alex. Alex, that's all the questions that we have for this session. Thank you for this comprehensive presentation, and I'm sure this is going to benefit a lot of people all over the world. Thank you so much for joining.
Thank you so much.